start off today by talking about myeloma in a big way. I'm not going to talk too much about specifics. It's going to be some myeloma 101, but most of it is going to be just laying the landscape for the speakers to come after me to give you the details. So once again, everybody, thank you for coming. And so with that, let's see. I'll probably take it from here. Okay, so multiple myeloma is the second most common hematological neoplasm in the United States, but it's not something that most people have heard of till they actually know somebody who's come down with the disease or have the disease themselves. It's second only to non-Hodgkin's lymphoma. It's a disease that is growing both in incidence and prevalence. There are roughly about 30,000 new cases or more expected to be diagnosed as of 2016. The number is probably higher this year, and probably that reflects partly the growing age of our population. And it also is a disease that's growing in prevalence, as fortunately we've made tremendous strides in the last 10, 15 years in this disease. The number of people carrying this diagnosis is probably somewhere between 125 to 150,000 individuals, and it's going to keep growing as I think the best is yet to come. It's one of the cancers in which I think the progress has been maximum in the last 10, 15 years compared to other cancers. Just as I said, a little bit of myeloma 101. What is multiple myeloma? It's a disease of what we call plasma cells. These are cells that all of us have in our body. They should number 5% or less of the cells in the bone marrow, and their purpose there is to provide immunity against infection. They produce what we call immunoglobulins to fight infection. In case of myeloma, we don't know what it is, but it's probably something in the environment. In most cases, there may be some small element of genetic predisposition, which some of my fellow colleagues will talk about. And this is something that confers a malignant phenotype to the cells, and that's when, unfortunately, problems arise. What are the common symptoms that patients present with? Most common is bone pain, fatigue, and weakness. Some people come to light because they come in with an infection, loss of appetite, weight loss, and about 10 to 20% are diagnosed relatively asymptomatic these days. They go into their local doctor for a yearly physical, are found to be somewhat anemic, or they have a high protein in the blood, and a workup is done, and then one is found to have myeloma. Myeloma does lead to several consequences. Not everybody has all the manifestations of the disease, but patients can certainly be anemic, low blood count. Simplistically speaking, if the bone marrow is full of cancer cells, there's no place for good healthy blood cells to be produced. It can cause kidney damage. It is something that is a result of the proteins that the myeloma cells make that go into the circulation and can gum the kidneys up. It can cause a propensity to infection in patients as well. It can cause bone damage. And the bone damage is pretty dramatic in multiple myeloma. What we see on x-rays often are areas that even you can all, I think, appreciate show areas of demineralization, and this is because, simplistically speaking, the myeloma cells are making chemicals that are making the calcium leach out of the bones and making them brittle, and in rare cases, the myeloma cells can even directly invade the bone. As far as the diagnosis of myeloma goes, it's a disease for which we do a number of tests. We do a blood count to make sure, see if one's anemic. We'll talk about this M protein test and light chains in a minute. We do a beta-2 microglobulin, which is a test that tells us how aggressive the myeloma could be. We do tests of kidney function. And then we do urine tests as well to look at whether protein is leaking out into the urine and what kind of protein it is, quantitated, and then used to follow that. The M protein or the monoclonal protein is something that everybody may have heard of. Most patients, about 80%, will have what we call an M protein, and this is the one that is either an IgG or an IgA in most cases, sometimes an IgM. This just illustrates what the laboratory is looking at when they're telling you what your M protein level is. So this is normal. So what happens is your blood is put on apparatus which runs current across it, and the protein in the blood constitutes various fractions, and it in a normal person is going to give tracing somewhat as you see here. In the case of multiple myeloma, what happens is that you're making a lot of the M protein, and that shows up as a big peak. And then you're trying to quantitate this peak. And this is a visual quantitation in most cases. So sometimes minor changes in the M protein could be also just because of who is looking at it at a given day. And it also depends on how you mark where the peak begins and where the peak ends. And so sometimes you go and have the test analyzed by two different people, and they'll give you slightly different values. They won't be off by too much, but I just wanted to say that sometimes a different lab or a different person looking at the test, it's not a computer-generated figure, can give you a slightly different figure. The other thing that is done is the light chain analysis. So this is what we call the thing that most myeloma cells or plasma cells make, an immunoglobulin. It is made of these two heavy chains and two light chains. As I said, 80% of patients make the full immunoglobulin, but about 20% of patients just make light chains, or 15 to 20%, and they are just the portion of the immunoglobulin shown here. They don't make the heavy chains. Until about 15, 20 years ago, we couldn't quantitate these. Now we can. The assay is called the serum free light chain assay. Now, in most patients, actually, you make both the heavy chain and the light chain components, so you can follow both. But in the 20% of patients that have light chain alone, then you can just follow the light chains. The light chains change more rapidly in level because they degrade faster in the body, and so changes in the disease may sometimes be reflected much faster in the light chain levels than in the M spike. The other thing that will be the subject of a later talk is that we do imaging in multiple myeloma. We have been pretty much focused for years on X-rays, but we are getting better technologies. On X-rays, one of the major sites is often the vertebral column, the back, where the pain is first noticed. And this doesn't project well, but this is a crushed vertebra. When you do an MRI, you can actually see abnormalities that an X-ray will not pick up. So this MRI will give you details that will often pick up disease before an X-ray can pick it up. A CT scan, and the other thing an MRI will do is give you more detail on soft tissues. If there's a mass of myeloma cells growing out from the vertebral column, it is a better test than a CT scan, which gives more detail on the bony structure, whereas MRIs are better for soft tissue myeloma masses. The CT scan is better for telling you about the level of bone destruction. And then PET CTs are, I think, the best in terms of telling you activity of the disease. This is a PET CT scan that shows you areas of activity. Cancer cells utilize a lot of glucose, and so the current generation of PET CTs relies on glucose utilization to tell you if there is areas that are what we call hot on a PET scan. And as the disease gets treated, we know the PET scans normalize. The MRIs take longer to normalize. The other thing we do, which not many people are very excited about, is a bone marrow biopsy. And the reason why we do it is multifold. We want to look at the plasma cells and quantitate them under the microscope. That tells us how many there are to start with before a treatment is given. But we also look at chromosomal features and what we call FISH testing on this, which tells us how aggressive the treatment, the disease is likely to behave. Now, myeloma doesn't rise out of the blue. It is a disease that, yes, unfortunately, most people are diagnosed with fairly abruptly, but the first changes of myeloma occur probably years and sometimes decades before it comes to light. And we have two precursor states, MGUS, called monoclonal gammopathy of unknown significance, which is just a medical term to say you have an abnormal protein. We don't know what it is going to mean for you. This is an entity that progresses at the rate of 1% per year to multiple myeloma. So patients diagnosed with MGUS 25 years later will have a 25 to 30% chance of developing myeloma. Smoldering myeloma, as we'll see in the next slide, just means you have more of these proteins in the blood, you have more of the cells in the bone marrow. they progress at a slightly higher rate of 10% a year for the first 5 years. So half the patients with smoldering myeloma overall do develop myeloma within 5 years. And then there are those that make it out between 5 to 10 years. There the rate of progression is 3% a year, and beyond year 10, it's 1% a year. So how do we diagnose whether you have MGUS or smoldering myeloma or multiple myeloma? Has undergone some change. As I said, the MGUS and smoldering myeloma distinguishing factors are the level of cancer protein and the number of cells in the bone marrow that you have that are abnormal. But more recently, we have changed the definitions of myeloma about 3 years ago. Myeloma used to be what we call CRAB criteria, which is elevated calcium, R for renal or kidney insufficiency, A for anemia, B for bone disease. But the fact is that we also know that when we picked up patients with smoldering myeloma, we did have patients, unfortunately, that we followed, because that's at the moment at least what is recommended, that unfortunately developed kidney problems or broke a bone, and you regretted having waited because you knew there was something that was brewing. So it was felt that if you could identify patients that had an 80% chance of progressing within 2 years of their diagnosis of smoldering myeloma, that perhaps they should be treated without waiting for bad things to happen. And so what was identified was that anybody who has more than 60% of the cells in the bone marrow being these plasma cells, those patients should probably be classified as myeloma. And then there were other criteria that were brought into the definition. Anybody with a kappa to lambda or lambda to kappa ratio, which is the light chain over 100, and then anybody who had more than one abnormality on an MRI scan should be classified as myeloma. I think there's still some controversy among specialists about whether these new patients that have entered the diagnosis of myeloma should be treated. The most powerful predictor is the number of plasma cells. So I think that quite a few physicians are certainly treating patients who have more than 60% plasma cells in the bone marrow as bona fide myeloma. I don't know that there is complete consensus about treating patients who just have a very small abnormality on an MRI and everything else being normal. Now, once you made the diagnosis in any cancer, you stage. You say, how are you likely to do? And the staging system in myeloma, you have 3 stages. And the thing is that the staging system has changed from what we call the international staging system to the revised international staging system a few years ago. And what this did was, earlier what we used to do is just look at what your blood albumin level was, and as I had said previously, what your beta-2 microglobulin level was. And based on that, we assigned a stage. But we became clear with the years going that with the work done by some of the people in this very room, that the patients that had adverse chromosomal features actually were the ones that were more likely to have progression faster. And so the staging system was changed to incorporate the effects of the chromosomal features. And so some of you may be familiar with these terms, but translocations where your chromosomes break and bind to other parts of other chromosomes define the stage as well. Translocations of what we call 414, 1416, deletion of 17p, these may not be something that obviously makes much sense to you, but these have been worked out elegantly, again, by a lot of people in this room. Gareth has done some of the pioneering work in looking at the molecular basis of myeloma. And the thing is that there are others that have other adverse prognosis, but not as bad. So based on this, without getting into details, some of my colleagues will, I think, elaborate on this. You can actually prognosticate in a more robust way, that you can have patients who have stage 1 disease where they live very long, whereas stage 3 disease average lifespan of 4 years. When this was published in 2015 using old data, but I think that we are probably already doing better for all of these patients. Now, just to lay the groundwork for what will follow, just an overview of approach to treatment. for all the plasma cell disorders. Patients who have MGUS, close observation alone is what is still recommended. For those who have smoldering myeloma, overall observation is what is recommended, though patients who have high-risk disease, which I did not get into, where there are factors that we can look at that can tell you who has a higher risk of progressing to myeloma. Those patients may be candidates for clinical trials. And certainly if there's bone loss, giving them a class of drugs called bisphosphonates, called Zometa or pamidronate, and now there's a new drug called Xgeva that has also been launched, can help preserve bone in these patients. But it's really when you have active myeloma that you need to consider treatment. And the fact is that the number of options that we have for our patients has exploded. This timeline goes back to the 1960s when the first really active drug for this disease was discovered, called melphalan. The next few decades saw the advent of newer drugs. These used to have patients respond better, respond for longer, but unfortunately when their disease came back, usually it came back more aggressive. And so we weren't able to change the life expectancy of patients. We went from about a year, 18 months to probably 2.5, 3 years with melphalan, and that's where we stayed. And then it was the advent of high-dose therapy, that is stem cell transplant in the 90s, that produced the next major advance in the longevity of patients. And a lot of this work was done at Arkansas. The fact is that since that time, this has been the treatment that is still recommended as part of the treatment for those who are relatively young and healthy. And then more recently, we've had newer drugs in this millennium come to the fore, and these include what we call proteasome inhibitors. These are the drugs that you will have heard of: Velcade, carfilzomib, ixazomib, or Ninlaro, and immunomodulatory drugs: thalidomide, lenalidomide, or Revlimid, and pomalidomide or Pomalyst. And then more recently, about 2 years ago, we had the advent of a whole new class of drugs called monoclonal antibodies. These work by targeting molecules on the cancer cells. They're not really chemotherapy. They're probably part of what we call the revolution in immunotherapy for multiple myeloma. And without going into any detail, I'm sure my colleagues will talk about this. As far as the treatment paradigm overall for myeloma goes, the fact is that there are about, as I said, 30,000 cases each year in the United States of myeloma. There are roughly about 6,000 patients who get a transplant each year for myeloma. It is felt you could double the number of transplants probably if appropriate referrals were made to transplant centers. So unfortunately, a lot of times patients are not referred into transplant centers. But for those that are transplant eligible, you generally give them a period of chemotherapy for several cycles, and then you go through the consolidative phase of a transplant. 1 transplant, 2 transplants. My colleagues, I think, will talk about this. I'm not going to get too much into this controversy. And then you go on to a maintenance phase of treatment. For those that are not transplant eligible, transplants are commonly done in people in their late 60s, even early 70s. Mid-70s, I think people start getting choosy, but there are patients that get transplants even in their late 70s. And so the fact is that for those patients that are not truly able to get a transplant, then you give them continuous therapy. So this is a paradigm that's evolved in the last 10, 15 years. Previously, in myeloma, we used to give patients treatment, and then we used to give them what's called a treatment-free interval, and it was felt that giving people time off treatment would improve their quality of life, and then you started treatment when the disease started becoming active again. But that was partly driven by the fact that even if we wanted to, our older drugs were not amenable to long-term administration. They had toxicities that prevented them from being given long-term. Now our new drugs are much more safer and well-tolerated. So the paradigm, which has been validated by studies, has become that you need to probably, as far as possible, try to keep patients on some treatment. You may vary the intensity of treatment depending on the phase of their disease, but ultimately you want to keep patients on treatment longer, and that has been shown to be improving the length of disease control and the longevity of patients. The goal of the initial treatment is to have as deep a response as possible, to improve the quality of life of patients, But for those who are transplant eligible, not give them drugs that will prevent us from collecting stem cells for a stem cell transplant. What are still unsolved issues, which some of these will be talked about, I think, by my colleagues, is what is the best treatment for a patient before they go to transplant, still some, how long they should get their treatment before the transplant. Those are things that hopefully my colleagues will talk about. And then MRD is something that was alluded to, and it is something that all of you, I think, have heard of. Minimal residual disease, MRD, is one of the hottest areas in myeloma. It is a thing that has been shown to predict for how long your disease is going to be in control and how long patients can expect to live. So it has become certainly something that is the subject of increasing investigation. So it can help us determine how patients are likely to do, as I said. And it can help us compare if one set of patients got one treatment and the other set of patients got another treatment. Roughly you can say how the drugs compared across the trials. But the real value of this is going to lie in when we can use it to make treatment decisions. And that is a place where we don't have consensus right now. Like, can we predict some patients who don't need a transplant if they're MRD negative before it? We don't know if that is true. If you have a patient who's MRD positive, if you give him more treatment at that point, will you change his outcomes? Or should you just wait for the disease to progress? Or in certain instances, when patients are on maintenance therapy, people after a transplant these days, on an average, have 4 to 5 years of disease control often. And so, these drugs are sometimes costly to patients. They're also got some side effects, though they become safer. So if we can get by with, say, 1 or 2 years of maintenance in the future, for patients who are MRD negative, that is a question that is still unanswered. There are trials that have now started where people are going to have treatment, and then if they're MRD negative for a period of time, half of them are going to continue treatment, the other half are going to stop treatment, and that will help us answer these questions, but the answers will probably not be known for several years. So to just overview of how patients are treated today, if you're a transplant candidate, you go and get induction and go to transplant. If you're not a transplant candidate, you go and get conventional treatment. That has also improved over the years, and people are living longer even if they're not getting a transplant. And as I said, we are, after the transplant or the non-transplant treatment these days, trying to keep people on drugs. And this is one study that showed that if you were, this was actually a combination of studies that were analyzed, and for patients who got lenalidomide after a transplant, their average life expectancy was 2.5 years longer than those who did not. So once you've treated, you're on maintenance therapy. Just to broadly say, what about retreatment? And this is something that, again, is as much art as it is science. Certainly when you have what we call a clinical relapse, when you're having symptoms or your laboratory work is starting to show changes, then changing treatment is warranted. But quite a few patients, in fact, maybe half or more of patients who are initially starting to have their disease come back is what's called the biochemical relapse. That is, they're not having any symptoms, their blood counts are fine, their x-rays are not changing, their calcium levels unchanged, but the blood test, the light chains, or the M protein is starting to wake up. So the textbook would say for these patients, observation alone is fine. There is no definitive proof that jumping early to treatment is necessary, but as the armamentarium of drugs is improved, and both patients and physicians do get a little bit anxious when they see that the disease is starting to grow. So who should you maybe start treatment even at the time of biochemical relapse? So again, there's no consensus on this. People say if you have high-risk chromosomal features, maybe treating early is better. Some people have said if your protein level is starting to rise faster, maybe you should treat. And others, including ourselves, often do a PET scan at that time. And if your PET scan is negative, then we're a little more likely to be a little conservative. There are a number of factors that we consider at time of retreatment. There's no one treatment that fits all. This includes how your disease has behaved, what kind of prior treatments you've had, And generally also each patient is individually different. Some patients have impaired kidney function, some are living far away and can't come to the doctor's office to get an IV drug, or their general health is not best for travel. So that does need to be taken into account for deciding treatment. As far as what we do, if patients have had more than 6 months of disease control, you can, even if you've stopped the treatment, reinitiate the initial treatment, or you can try a different treatment. And some people, especially our cutoff is if you go 2 years or longer, could even get another stem cell transplant if they've had a transplant. But if your disease comes back within 6 months, then I think different therapy, or if you've not had a stem cell transplant, then doing a transplant at that point would be imperative. So the principles around relapse and refractory therapy are, because no therapy is unfortunately for most people at this time curative, all options have to be tried sequentially, and there's no optimal sequence. This is something that each physician may have their own preferences on, but there's no specific rules that tell us how we give one treatment and then the other and then the next. And a lot of this has to be done to try to achieve the best balance between efficacy and disease and toxicity. And just to wind down, where are we going? And this is the subject of a lot what's going to come. We do have a lot of more drugs in clinical trials. So it's not as if the pipeline is running dry, and these are drugs that are out there that are showing activity. And obviously, I think everybody in this room has heard of CAR T cells, and that, again, is a modality that is very exciting. It is showing tremendous potential. We don't have long-term results, so we can't be sure how durable a lot of these responses are going to be, but the hopes are high. And then the other thing is that we're understanding more of the biology of the disease, and we're realizing that not only attacking the cancer cell, but also tracking the cells in the environment is important. The fact is that cancer cells in the bone marrow live in a milieu of a lot of other cells. And we know that if you take cancer cells and put them in a petri dish in the laboratory, you can actually kill off the cancer cells. If you put them on a layer of normal bone marrow from a normal individual, those cells still can live. But if you put them on a layer of bone marrow from their own diseased bone marrow, they don't die with chemotherapy. That tells you that there's signals from the environment of the cancer that are also important to keep the cancer cells alive. So, tackling the environment is another thing that we need to be doing. And then obviously everybody's heard the buzzwords of personalized medicine, trying to get treatments that are particularly tailored to each individual, and this is going to be the subject of a lot of the genomics talks that are going to follow. And the hope is that we are on the cusp of era where we can tailor treatments to each patient's individual cancer genome. The promise is there. The other thing is precision medicine, which again is often the same thing as personalized medicine for most people, but some people have a distinguishing factor, and that is precision medicine is that you actually become agnostic to what kind of cancer even the patient has. You actually just focus on their genome. And if you have certain changes in the genome, no matter whether you have got breast cancer, colon cancer, or myeloma, you get the same treatment. And the very first drug on that paradigm was approved last year by the FDA for what we call microsatellite instability cancers, where whether you had colon cancer or, for that matter, breast cancer, if you had a mutation in those genes, you could get that drug. And that was obviously a paradigm shift and probably the first of many to come. And we're going to have to change our trials as we go forth. And the fact is that we nowadays have this paradigm of going through phase 1, phase 2, phase 3 studies. Phase 1 is when we escalate the dose of the drug. It's got theoretical promise. We're trying to find how safe it is. When we find a maximally tolerated drug dose, then we give it to about 50-odd patients and see how active it is. And then once it seems to be active, we do what's called phase 3 studies, which is that you give the patient the new drug, half the patients, and the other half what is treatment minus that drug, and show that your drug makes a difference. And this takes the better part of often 5 to 10 years from the time of discovery. So this is a long process, and this has got to change. And it will also have to change because, as you saw, myeloma is 30,000 individuals. If we start breaking it into buckets of 200 patients or even 2,000 patients with one kind of genetic disorder, the incentive for pharmaceutical companies to develop drugs tailored to just 500 patients in a year starts becoming less. So that is where we're now getting into these what we call umbrella trials, where a lot of companies are coming together to support one study in myeloma, and you get your treatment based on what kind of mutation you have. And that takes a lot of effort to get a number of different pharmaceutical companies to support one clinical trial. It is more their lawyers than anybody else that you have to convince. And then there are these basket studies where, as I said, you don't even worry about what kind of cancer you have. You just say, okay, we can't target mutation X in myeloma in an economically viable way for a drug company, but how about if we put all the people with all kinds of cancers with that mutation into a bucket and tell the pharmaceutical companies to develop a drug for that mutation, then it becomes not just 2,000 patients with myeloma, it could become 50,000 patients with that mutation. So these are, I think, things that are evolving. And just to say that here at Washington University, we are part of this effort in a big way to help our patients. We have focuses on myeloma, biology, and immunology. Again, the number of people focused on myeloma here is not just myself here. There are probably 50 to 100 people who work on the various aspects of the disease, right from finding better understanding of the biology to genomics and personalized medicine, to nanotechnology, which you'll hear about, which is a big center that we have trying to develop new methods of drug delivery. And as you'll hear, imaging is another very strong point at Washington University. Mallinckrodt Institute is where the PET scan was invented for the world. This is a place where a lot of discoveries have happened. And in the Midwest, we're not very good at marketing ourselves. Often, one of the things we often hear from external advisors is you need to be on Twitter and you need to be on Facebook. And we're a little bit conservative, unfortunately, so we don't do as well. But we have a great group of people, clinical trials. We have contributed to the development of all the recently approved drugs. And we have a big focus on healthcare outcomes research, looking at large databases to look at disparities in cancer care, myeloma cancer care delivery, treatment of elderly patients in multiple myeloma, and also healthcare utilization. So the hope is that we're going to come from an era of ineffective therapy, which we've left behind, to treatments that produce deep responses, but unfortunately patients do relapse, to hopefully learning from the biology to get to a point where we are curing patients. So with that, I'll just say thank you. Went over a few minutes, apologize. And I don't know if you are planning on questions after each speaker or later. Okay, thank you. Appreciate it.